Now, it's my pleasure to introduce Pejman Ghanouni, who really is well known as anybody in this field. He's a radiologist at Stanford. He's a leader in focused ultrasound on the global stage. He's a pioneer of focused ultrasound treatment for a variety of indications. He's one of the driving forces that's made Stanford a powerhouse in focused ultrasound. He's helped assemble an incredible team, including Kim Butts-Pauley, Kathy Ferrara, Zhua. He's created truly an interdepartment, multidisciplinary effort that's been recognized by the foundation as a center of excellence. Pejman, it's a pleasure to introduce you as the honorary president.
First, I'd like to thank the Focus Ultrasound Foundation and Neil for the privilege of serving as the honorary president of this symposium. To be frank, on the one side, I'm not a senior clinician or scientist. I can't present to you decades of results to show you what we've been doing, and so there's not much to praise and laud for a long career. This is really at the beginning of my career within Focus Ultrasound. On the other hand, I've built likely the busiest and most diverse Focus Ultrasound service in the United States, and that experience will serve as the basis for this talk. I should note that my experiences are sometimes unique to the United States and sometimes even unique to a tertiary academic center within the US. My background clinically is in MRI, and my expertise is with MR-guided focus ultrasound, so hopefully you can forgive me for the limits of my knowledge in other areas, but the experience I hope to share with you and my insights into the development of the technology and the adoption of this technology, and also what I perceive to be the challenges and opportunities available to us. Sometimes this process seems Sisyphean, but we've managed to reach new heights, as Neil was referring to, along the way, and hopefully my experience can help enlighten yours. So this represents the growth in our service volume at Stanford. This was from one case at the end of 2012 when our 3T magnet first got installed to about 80 cases this year. You can see some peaks and valleys in this growth. This represents variables such as FDA approval coming along, the opening and closing of clinical trials, insurance coverage policy changes. At this point, we're limited by the availability of the magnet as well as the availability of my time, which are factors that I can talk about later. As of now, I treat uterine fibroids as part of a women's health center, most often in patients interested in future fertility, in women who are trying to avoid surgical myomectomy. We've also recently branched into treating adenomyosis as well. I treat bone metastases. As you can see in these PET-CT images acquired a few weeks before and a few weeks after focus ultrasound, FUS can be used not just to palliate pain, but to control tumors. We'll hear more about that in our upcoming seminar sessions in the musculoskeletal section. Recently, we've branched into the treatment of osteoid osteomas. Someone advance the slide, please. Thank you. Some of these have been treated off-label, and most recently have been treated by a Focus Ultrasound Foundation-sponsored multi-center trial headed by Dr. Matt Buckner at UCSF. We also treat desmoid tumors, which actually spun off of a clinical trial that we established to treat sarcomas. This is an example of a desmoid tumor in the palm of the hand of a young man that we treated, and you can see that the tumor's essentially gone away after the treatment. And finally, we've grown into the treatment of essential tremor. We treat now also tremor-dominant Parkinson's disease off-label, and we're part of the Parkinson's dyskinesia trial that's using focus ultrasound for pallidotomy in patients. Again, you can see the dramatic results after that ablation in the left thalamus. The patients basically scrawl, inability to draw a spiral, inability to draw a straight line, illegible handwriting within a few hours of this treatment. During the treatment, you can see the dramatic effect that it's had. And finally, to the latest application, which is in prostate cancer, in clinical trials at this point, we're using focus ultrasound to treat intermediate risk focal disease, something that's very promising, about which I'm particularly excited, as it marries focus ultrasound to MRI, I think both in a very essential fashion. So what have we learned and how can we apply it? There's a number of keys to clinical success, and the model that we've chosen is that of a center of excellence. The issues that I believe are critical, one, I believe the approaches that we need to take need to meet an unmet clinical need. Obviously, one needs to have the requisite team, but in addition to that, and probably most critically, there has to be an established referral pattern for patients. There has to be a way to manage reimbursements, and these have all proven challenges along the way. The approach we've taken, as I said, is a center of excellence model in which FUS sits at the center of a women's health center, at the center of various oncologic applications, at the center of a movement disorder center within neurosurgery. This model has a number of advantages. There's a halo effect in which, for example, within our fibroid center, patients are evaluated by a number of experts, both gynecologists, interventional radiologists, and MR specialists, who can provide expert insight into the clinical and imaging aspects of the disease and talk about a range of clinical treatment options. This is very attractive to patients because of the thoroughness of its care. The referrals are automated. The gynecologist has become my favorite friend. She's constantly sending me patients and asking whether I can help treat these patients with focus ultrasound. This has led to not just clinical but also research collaborations. This approach is quite successful, I think, in managing that challenging referral-based issue that we mentioned. Now, I want to apply what we've learned a bit and drill down, and I should emphasize that these are just my opinions, and also that this is retrospective. We know much more now than we knew when some of these applications first started. But I want to kind of think back retrospectively and see how what we have learned in the process of meeting some of these clinical applications can influence what we choose to do in the future. So for example, taking uterine fibroids, is this an unmet clinical need? Yes, there's a large patient population, there's FDA approval for the treatment. Has it met the evidence requirement? Some would say yes. An established referral pattern? Well, we talked about our center, but in general, it's challenging to get gynecologists to refer. Is it reimbursed? Is it easy to do? Reimbursement has proven a challenge. As far as easy to do, the device is designed for this approach, so technically it is fairly straightforward for positioning. But here's a more pessimistic impression. Is there an unmet clinical need? Well, it depends on who you ask. If you ask the patients, of course they're looking for a uterine-sparing approach. If you ask a gynecologist, they would say a hysterectomy stops all bleeding. And whether it's fibroids or whether it's adenomyosis, is a very effective approach for treatment. So our threshold for meeting an efficacy standard is very high in comparison to that approach. Obviously, the surgeries have now become much more minimally invasive. These are being done now laparoscopically. The incisions are tiny. Patients are being treated as outpatients and going home the same day. Their recovery is within a few weeks, 2 weeks to maybe 4 weeks or so after the surgery. That makes it much harder for us to compete in that setting. So it depends on the perspective as to whether it's an unmet need. Definitely a large population. By age 50, 70 to 80% of women have fibroids. FDA approval, yes, but have we met an evidence requirement? Again, it depends on who you ask. The people that do the procedure know that it works, but if you ask insurance companies, for example, they ask, where's the randomized control trial comparing this to myomectomy or embolization? It's proven very hard to recruit to those types of studies, and I think that's what's led to challenges with referral as well as with reimbursement. Now, should we just give up on this application? I think not, and I haven't given up on it, and it's in particular because I found that in an area within fertility, it's still proven to be quite valuable to patients as well as to their gynecologists. Right now, for women who are interested in preserving future fertility, surgical myomectomy is the only option. Even done laparoscopically, these women need to wait 6 months before they can try to get pregnant, and they have to deliver by C-section after the surgery, or at least it's strongly recommended that they do. So here's an unmet clinical need. We can avoid the need for surgery, and women can potentially deliver however they choose. There's a growing patient population as women have chosen to wait later in their lives to become pregnant. FDA approval, well, no, not initially, but more recently the FDA has changed the label to allow us to treat women who are interested in future fertility. Have we met the evidence requirement? No, no studies have been done talking about, in a large scale, comparing fertility outcomes of focused ultrasound to myomectomy. Is there an established referral pattern? At least at our institution, we've been successful both within the fertility group as well as within gynecology in treating these patients and in getting these patients referred to us, at least for screening purposes, to see whether they're candidates. And it's currently not reimbursed. So the challenge here, of course, is do we want to choose to pursue a trial or some study that would meet the evidence requirement? Because that's the essential purpose of, essential need for reaching reimbursement. What have we learned? Well, there's a difference between what patients want and what referring doctors are willing to support. So even though the patients desire uterine-sparing treatment, not all gynecologists are willing to support this. The lack of a randomized controlled trial has negatively impacted our ability to obtain insurance coverage in the United States. And there's limited efficacy from the initial studies because of the FDA limits that were imposed. Initially, we were not able to treat more than 30 to 50% of the fibroid. Unsurprisingly, the durability of such a treatment is not high. So at the end of the day, remember that a woman, even if we offer her something that gets her back on her feet within a couple of days, in a year, if her symptoms are back, she doesn't really care. What she cares about is that her symptoms are gone and durably removed. So we have to address not just the quick recovery, but the durability of the results. How does this influence now the bone metastasis application? An unmet need? Absolutely. 75% of patients with cancer develop bone pain. Maybe a half to two-thirds of them are adequately treated by radiation. There's a large and growing patient population as our chemotherapy and systemic approaches to cancer treatment have increased in their efficacy. More and more patients are living long enough to develop osseous metastases. It's FDA approved. Do we meet the evidence requirement? Absolutely. And we should laud the vendor in this case. Not many device companies go through the process of a randomized control trial to prove the success of their treatment. Here we have a sham-controlled study that incontrovertibly showed that this treatment works for the palliation of pain in patients that have had prior radiation. And as a result, the treatment has been reimbursed. There's no argument from the insurance companies. And frankly, this is the easiest treatment to do. I can talk about that more in a bit. The challenge has been the referral pattern, and I'll talk about what that means. We haven't seen as many patients referred for bone metastasis treatment, in part because FUS sits among really a menu of different options for treatment of pain. And right now, radiotherapy remains the standard of care. So what have we learned? Well, an RCT, as opposed to for fibroids, the randomized control trial here was sufficient for gaining insurance coverage. FUS treatment of bone is easy to do. That's another thing that we've learned. This is actually something that could be done by a technician after a radiologist or interventionalist planned the procedure. Not many of our procedures are that way, that someone could plan the procedure and walk away. In a way, it's akin to radiation oncology in that way, that you can plan a treatment plan for radiation delivery, and then someone else can actually follow the plan. I believe the same thing is true for these bone treatments. But are bone mets an unmet need? Well, radiation works well in a majority, and radiation is easy to deliver. It doesn't require an MR. It doesn't require anesthesia. So again, it's a challenging environment to compete in, and it can be very hard to overcome these established referral patterns. In particular, there's a long-standing relationship between medical and radiation oncology that has made it hard for us to intervene and kind of show the opportunity that's available for focused ultrasound. Again, should we give up? Well, the main limitation is referrals. And again, I mentioned that bone is the ideal target for FUS. One area that I've seen as a way to get around the referral issue is the growing area of palliative care within oncology. The palliative doctors don't care what makes their patient feel better. Is it an injection of steroids or anesthetic? Is it focused ultrasound? Is it radiation? Whatever it is, they want their patient to feel better. And so these doctors have been much more open to using focused ultrasound for the care of their patients, and they've been a good resource for referrals. I'll also mention that the field of oncology in general is very open to data. This is a quote from one of my oncologists. She referred a patient to me to treat a radial metastasis that had been previously irradiated and at another hospital. So they came to our hospital, and the radiation oncologist was getting ready to irradiate it again. And our medical oncologist said, no, I want the patient to pursue HIFU. She knew the data, and she said, quote in an email, HIFU is for previously irradiated areas that are painful, end quote. End of email and end of story. The patient got HIFU. And again, it's the data that drives the utility and the use of this technology by the referring doctors. So if we had an RCT, for example, that compared focused ultrasound to radiation therapy, I believe it would move the dial. The question is, are we going to pursue that or not? I think that some of that data is on the horizon, and we should hear about it from some of our colleagues here at this symposium. Finally, essential tremor. Here, I think we really check all the boxes. Unmet need, a large patient population, FDA approval. Again, we met the evidence requirement here with a randomized controlled trial, established referral pattern. Patients are coming to neurologists or neurosurgeons for this care, and it's being increasingly reimbursed. Very few states left that don't have coverage now, and it's relatively easy to do. So now why am I going over this? Because I feel that the field is in an inflection point. We can go from my graph of relatively slow growth with peaks and valleys to hopefully a much more rapid growth in the volume of patients. But what do we need in order to do that, I think? Well, we can maybe use what we've learned already to inform some of our future directions. Neil talked about a lot of the different exciting work that's going on, but where should the emphasis be? Hopefully with some of this retrospective view, we can gain some insight into maybe where to put some of our future direction. Prostate cancer, for example, liver tumors, pancreatic, brain tumors, Alzheimer's disease, all of these are upcoming, but where should we emphasize our results and what are some of the challenges? Well, with intermediate risk prostate cancer, I think that there's a real opportunity, in part because men have gone from whole gland treatment as a standard of care. The dial has swung to active surveillance for many of these men that have low-grade disease. But as we know, by about 5 years, many of the men in active surveillance, maybe about 40% of them, have ended up getting some kind of treatment because their disease has progressed. So what that means is that there's a group within active surveillance, and then there's also a group within this middle ground of intermediate risk disease that are candidates for focal therapy. And what we've seen in our clinical trials so far is that the results are very efficacious and that men are able to preserve their continence and preserve their erectile function. It really seems to be the trifecta. Again, the data is early. We need to still amass the results. And the real challenge in prostate, of course, is it can take years to finally see the results in terms of efficacy. But in terms of side effects, it's proving to be what we hope. So it's an unmet need. There's a large patient population. What we need to do is to get FDA approval and meet the evidence requirement. In terms of the referral pattern, the urologists are very supportive, at least at our institution. And again, this is fairly easy to do with a device that's really designed for this. And again, you can see the value of this. That top image shows you the cancer in the bottom left portion of the peripheral zone of the prostate. It's very easy when you can see the thing to target it and ablate it. And that's what we do in the bottom image there. We're basically planning the treatment to encircle that area and completely ablate the tumor while leaving the neurovascular bundle alone. Again, you can see the advantage here of MR. There are places where ultrasound guidance is adequate or more than enough, but in this aspect in particular, MR guidance seems quite valuable. The challenge, of course, is going to be meeting the evidence requirement. The FDA thus far has been willing to say that these treatments with focused ultrasound are adequate for treating prostate tissue, but they haven't come around to saying they're interested in using it or approving it for treating prostate cancer. So how do we get to that stage where we either get approval from the FDA for this coverage or that we get insurance companies to say that this is valuable enough to do and let us treat these patients? You can see the patient demand is there, but meeting this evidence requirement is going to be a real challenge. Pancreatic cancer, another unmet clinical need, another relatively large patient population, and not in terms of many patients getting pancreatic cancer, but in terms of many patients now dying as a result of pancreatic cancer because there's so few options available to them. So this really provides a fantastic opportunity for focused ultrasound. So for prostate cancer, the questions are, can we conduct a randomized control trial? What are we going to compare it to? Radiation, prostatectomy? It'll take years to see the results of such a comparison. Can we reach reimbursement without a randomized controlled study? Can we, for example, show how much money is saved by avoiding prostatectomy and radiation, even if the results are 80% efficacious, if 80% of the men end up not needing whole gland therapy? That's a huge cost savings for the insurance industry and for the healthcare system. We have to somehow prove that. For liver tumors, is there an unmet need? Well, percutaneous ablation works really well. Microwave ablation, radiofrequency ablation. Is an MR-guided FUS approach necessarily the best next step? Is it as easy as the current standard? Perhaps, perhaps not. Maybe the ultrasound-guided histotripsy approaches that some are pursuing are a reasonable competitor for the current more invasive approaches. For pancreatic cancer, there's a number of technical challenges. There's bowel in the way, there's vessels all around. These are technical approaches that must be overcome. On the other hand, the need is very obvious. And one particular approach that we need to explore is, can focused ultrasound elicit an immune response in these patients? For brain tumors, is a primary metastatic disease that we should pursue? Do we do just BBB opening or ablation? All these questions are pending. For Alzheimer's, do we understand the pathophysiology well enough to pursue this as an application? So I have three proposals to conclude with to maybe try to address some of the questions that I've raised. I think that the main thing is something that's really sponsored here by the Focused Ultrasound Foundation is fundamental research. What am I talking about here? Well, I think there's a number of things that we really don't know yet, and I've chosen some examples. This is an example of a patient that I treated with who has this tremor in her dominant hand. This is a canonical treatment. You can see what looks like, on imaging, a perfect ablation in the nice location in the thalamus. She had absolutely no improvement in her tremor at all after this treatment. Well, why is that? We really tried to dig into this to see why. We looked into our patient's tractography. This is diffusion tensor tractography. These are the results in a normal patient connecting the hand knob to the thalamus. And you can see the streamline count. The yellow area shows the streamline count is quite high in the standard patient. In these patients that have such tractography, this is the typical result in their tremor scores. Really nice improvement in tremor scores, very durable results. Now let's look at this patient. Almost no streamlines. It almost seems like there's nothing connecting the hand knob to the thalamus in this patient. And in this patient, as well as in a couple of others that we retrospectively found in the clinical trial, there was no improvement in their tremor scores, and there was no significant improvement, and there was no durable results. So a number of people have talked about using DTI tractography as a way to improve targeting, but perhaps it should be used as a screening component here as well, to pre-screen patients. Again, this needs to be evaluated further. Again, there's a lot that we don't know. Here are wonderful results from the team in Barcelona looking at the use of HIFU for treating pancreatic cancer. We have a survival estimate that shows that these patients are living longer than expected. On the other hand, this is an uncontrolled group. There's a referral bias or sample bias in this. What we need to see is this compared to a control arm. But looking at these results and looking at our results in desmoids, I showed you the patient that had a desmoid tumor in the palm of his hand. Normally, when I treat a desmoid tumor, I treat it incompletely. It's just for control purposes. It improves the patient's symptoms, but the tumor doesn't go away. It comes back, I treat them again. In some patients, maybe about 10% of the patients that I've treated, a partial treatment results in complete reduction of the tumor. The tumor disappears. That's what's happened in this patient whose tumor in his hand went away, even though you can see in the middle image there's still some remaining tumor. Are we activating the immune system? Perhaps. Maybe that's what's going on, but we need to figure that out if we're going to rely on that modality. Here's another example. This was a patient treated by Dr. Yamaguchi in Tokyo, a patient with epilepsy. He tried to target the hippocampus. The temperature didn't reach an adequate temperature for ablation, only 48 degrees, but the patient's seizure-free. Is this neuromodulation? Perhaps. We need to explore these. So there's a lot that we don't know here, and we need to apply these, I think, to further our understanding and how we approach the remaining applications that we're pursuing. Another proposal is to fund research fellowships within neurosurgery, within interventional radiology, within urology. I believe that we should be funding doctors to come to leading institutions and learn from experts how to do these procedures. There aren't enough people that know about this within the general community, and I think we should somehow sponsor these interested fellows to come to institutions and learn about this, and then go back to their own institutions and become the advocates and experts at their sites as well. I think this is something that's a relatively low-hanging fruit for us to promote, and I think it would really help to expand the application. And finally, for funding, there's a number of things that I think are limiting the funding challenge. One, I feel like we have to move beyond the pantheon. Looking at the audience, I know many of the people in the audience by first name. I can say Wadi or I can say Alessandro, and everybody knows who I'm talking about. That's great. We have a close relationship. But where's the challenge in that? It means that when I submit a grant to a funding agency, half the people, anybody that knows anything about focus ultrasound, I've worked with. And so they have to recuse themselves from actually evaluating my grants. We need to have a larger population of people within the funding agencies that are aware of this technology, aware of its potential, and are then open to its application. That's a real missing component. And as a result, we have frustrations such as when I submitted a grant for prostate cancer treatment, everybody that I work with that knows about FUST recuses themselves, and the responses I get back are from a radiation oncologist who says things like, "Why would you want to do this? Radiation is perfect." That's a literal quote, and I would say most patients would disagree with that. So we have to promote FUST to the funding agencies. And a final proposal would be to establish challenge prizes. There's examples from within SpaceX. At Stanford, there's a group that yearly competes in a solar-powered car initiative. These people put in many multiples of the value of the prize in terms of their effort and time into pursuing the development of new technology. Right now, we have various academic centers, for example, working on modeling penetration of ultrasound through the skull. Why don't we establish a $1 million prize, and all of a sudden Google and everybody else that has a bunch of engineers that are interested in these kinds of projects brings their power and their computational, their expertise and their computational power to bear to treat these kinds of issues. What about the application of artificial intelligence to treatment planning? Right now, when I treat a fibroid, the device treats it as though every part of the fibroid is homogeneous. In prostate cancer, the same thing. It treats it as though the whole prostate is homogeneous. This tissue responds very heterogeneously. Excuse me. And as a result, I think what we see is that the tissue heating is very heterogeneous as well. If we applied artificial intelligence choices to the development of the treatment plan, one can imagine that the thing modulates its energy as it's delivering the energy, knowing how the tissue is going to respond. This is again an area where I think a challenge prize will be very interesting. I want to conclude by acknowledging my collaborators, and I want to leave you guys with a clinical story that I think hopefully empowers and it serves as an example of what motivates me about this. One of our patients recently was in her 80s with essential tremor. And when I called her to talk with her about her upcoming treatment, she was very difficult to understand because she had vocal tremor as well as hand tremor. So she asked whether or not we could treat her vocal tremor as well. And we told her, well, let's see how the hand tremor treatment goes. If there's no side effects during that treatment, maybe we can try. But we told her it's an off-label application. I can't tell you how efficacious it'll be. I can't tell you how durable it'll be. But she was willing to try. So during the treatment, we did the treatment. We got great results in terms of her hand tremor. And so we moved the target a little bit to try and improve her vocal tremor. I called her a few weeks later to see how she was doing. And the first thing I noticed, of course, is I could understand her much better. And she really shared a very powerful story with me, which is she was in her 80s, as I mentioned, living by herself. And so you have to imagine how isolated she was. She couldn't really use the phone because she couldn't dial. And when she spoke to people, nobody understood her. So she went from that to suddenly being able to use the dial, to call people, to have friends and family understand her. It's a really dramatic impact that these treatments can have, and it's the kind of thing that really motivates me and makes me very excited about what we're doing here. In a way, I feel there's an obligation that we have to pursue this technology, because I think it really has an opportunity to make a really dramatic impact on the lives of our patients. Again, I want to acknowledge my collaborators, particularly Dr. Gambier, Dr. Vasnawala, and Kim Butts-Pauley, who served as a mentor for me. Thanks very much for your attention.